Hello, everybody. How are you? And thanks for sticking with us this late. You know, yesterday, Andy von Eschenbach, former head of the FDA, former head of the National Cancer Institute, said that he would describe what's happened in medicine as a metamorphosis. That we've gone, that the current curative environment compared to the chronic treatments that we had for most of healthcare, the butterfly of curative treatments is as different from the old days as the butterfly is from a caterpillar. So I was thinking about that, and he's absolutely right in terms of how we've moved from chronic care to curative care. But in terms of the health system, when I was thinking about metamorphosis, it put me more in mind of Kafka's novel, in which a young man wakes up and he has turned into an Ungeheuerige insect, which is German for an awful-looking insect, and he's on his back, and he can't even roll over. That, to me, pretty much sums up our healthcare system today. Whether you think it's a broken snake, or whether you think it's a bug on its back that can't get up, this system is not a system. Or as I'd say, it's a string of pearls minus the string. So before we came up here today, I Googled cancer doctors in my hometown of Blytheville, Arkansas. Now, when I grew up, you could only get cancer on Tuesday or Thursday, because that's when the doctors came over from Memphis. I looked, and there were a lot of cancer doctors listed in Blytheville, Arkansas, and they were all 60 miles away in Memphis. Today, November 7th, 2023. So are we making progress? I think we all know the answer to that. Parts of the snake are doing really well, but the snake as a whole is still lying in pieces on the ground. So we've got a lot to deal with here today, because if we're trying to make predictions for the next 100 years, I asked the group in our preparatory call, what about the last 100 years? So Judy made a great point that the development of the pill was a huge event for women in the 20th century. And now in the 21st century, the Supreme Court has decided that abortion is no longer illegal under the Constitution, based on the writings of 16th century people who believed in burning witches. And as a result, a lot of the red states are now trying to outlaw birth control, as would Clarence Thomas. So what was a wonderful thing in the 20th century for women now may be taken away from many women. Penicillin. We're coming up on an anniversary of Fleming's discovery of penicillin. Discovery meaning that when he came back from a long weekend, he discovered it was on his desk. And now we're dealing with the problem of antimicrobial resistance because of human behavior and misuse of antibiotics. Vaccinations. I remember when I first got the polio sugar cube when I was a kid. I've had a friend who recently died of the adult onset of polio that he had as a child. So vaccinations have saved millions of people around the world, and yet what's happening today? Tuberculosis is back, polio is back, and people are saying vaccines are the enemy, not the solution. So if 100 years ago, when my mother was born in 1923, she's still alive, and you had predicted the health system of the next 100 years, wouldn't you wanted to have predicted that we would eliminate diseases for which there are vaccines? We liberated women from having somebody else decide when they had children, that we eliminated a number of the infectious diseases of the world, and all of those things happened, and now they're all unhappening. So predicting the next 100 years is going to be very difficult for one reason: it includes human beings. We are the problem. We know the science is not the problem. Science is now starting to be the answer after millions of years of humans on Earth. We are the problem. So I want to start off by, I'm going to ask each of the people on the panel to talk about how they particularly are building the future of the health system, both in their companies where they're working, what their mission is for the future of the health care, but also what they personally are doing based on their own vision of what the next century could be. So, Judy, I want to start with you because I want you to look ahead to 2067. We're at the midpoint between when you started Epic in 1979 and 2067. We're 49 years away or 44 years away from both. You started Epic based on the lore of how you founded Epic because somebody asked you they needed help in putting a billing system together at a hospital, or at least that's what it ended up being used for.
No, that's wrong.
Okay. Well, I'll have to show you the story I read where they said, oh, okay, we'll use this for billing. But let me go back to the point. You probably didn't have any idea of what the next 50 years of EMRs would look like when you started Epic. But everything Rob just said about how we can use data to improve our healthcare system involves a ubiquity and an easy access to all of the things that happen to us that we call medical data. How do you see that happening in the future? And how do you see Epic changing to make that happen?
Well, first I'm going to correct the billing thing.
Okay.
Epic got started because when I went to University of Wisconsin in graduate school in computer science, I took probably the world's first class in computers and medicine taught by Dr. Warner Slack. And he asked me to work with him and his team. And I said, okay. And did a number of projects. And they brought me in and said they wanted me to develop a system that would keep track of patient clinical information over time. No matter whether the patient was there once or 1,000 times, whether it was inpatient or ambulatory, they wanted that continuity of care of the patient. Well, back then, Meditech and Cerner were doing lab systems, IDX was doing a billing system, and we didn't know of anyone who was doing a clinical system such as that. So I went away for about a year, and it was tricky because you had to look what went on in the past for the patient, what was present, and what was future. And then some of the data would never change, like your birth date. Some of the data would always change, like your vital signs. And some of the data changed occasionally. That's mostly what we're made up of, such as your marital status, your operations, and things like that. So I had to figure that out. And in particular, they wanted to be able to design their own screens and define their own data elements. And this was before Oracle or Sybase or DBase or what we know as database management systems. So how to do those things, and then when I did it and worked at the University of Wisconsin, the people I worked with in lots of different departments would tell their peers around the country, and then I would get the call to say, start a company, and I kept saying no until I said yes. We didn't know how to do billing. And then maybe after 5 years of doing clinical systems, someone called us up, wanted a billing system, one of our customers. We said, we don't know billing. They said, it's really easy. You just add up the list of expenses that accrued to this patient, you send them the bill, the patient will pay something, you subtract it, and you keep the running total. So we charged them $3,000 for the first billing system that we ever wrote, which probably cost us like $3 million to write it. So, okay. Hopefully, everybody is cleared of that error. It's a common error, though. So what's going to happen by 2067, I have no idea, first of all. When you look at the big things that have changed our industry, a lot of it is what has come from other technologies. So when graphical user interface came along, we wanted to jump on that, and that made it much easier for the doctors to be hands-on rather than the old character-based line-by-line green screens. Then you had the iPhone that came along, and suddenly we could put things on the iPhone. Now there's AI, and I think that's going to make a lot of changes. I have no idea what clever things are going to be thought up out in, not in the world we work in, but outside that we can bring in. Secondly, I do think that there will be a lot of change because of the AI that we're going to work on. And I'm hopeful that that will make a lot of good changes, but I'll let you ask the other guys what they think.
Hirsh, full disclosure, I'm a paid advisor to Palantir, so I'm going to ask him the hardest questions. Hirsh, Palantir has worked with all the health agencies to aggregate data that previously was really hard to gather, to give a picture from above in a way you can visualize the environment that we're all in, and whether it's COVID, whether it's cancer incidences, whether it's pollution and cancer incidences mapped on each other. So number one, how do you find all of that data in a discombobulated, often very parochial data environment in the healthcare system? And secondly, knowing where we are is great, but how do you use it to know where we're going to go? And how does that affect your view of the future of healthcare?
Yeah, great question. I mean, I think it's worth maybe the brief origin story of Palantir here, which is the fundamental principles with which Palantir was started was that there's this age-old view that privacy and security need to be traded off with one another. And that, I think, particularly was in a national security context where, in a post 9/11 world, we really needed software to help bridge the gap and both protect the data of the citizens of the United States and also provide the infrastructure to help us get ahead of and address potential threats to the country. That ultimately resulted in us building a software platform that helps integrate data that organizations already have access to into one place, but critically locking that down, securing it, and providing the federal government with the tools to provide governance and auditability and interpretability on top of all of that information. The second half of that, which I think really gets to the second half of your question, is not just having information in one place so that we can create analytics and dashboards and run models, but actually really so that we can connect it to the decisions and the operations that an organization needs to run. And so that's, the epidemiologists every day at the CDC, the researchers at the NIH, the supply chain experts on the ground at a number of commercial distributors, really having data at their fingertips to make the decisions that they need every day. And I love what Commissioner Killif said before this, which is we need to get back to the point where clinicians are spending the majority of their time focused on providing care rather than munging data and filling out forms, and that's where software, technology, AI needs to go. And so when I think about the future of healthcare, where Palantir's role is in all of this, helping really provide a centralizing force across this incredibly fragmented ecosystem without pretending to have a silver bullet and accepting that all data is going to be in one place, really prioritizing security and control and auditability has always been important, and we've seen how much that resonates in healthcare, but it's becoming incredibly, even more and more important as we think about bringing AI into these contexts and ensuring that interpretability, model readiness and bias checking, all of that is part of the way that AI factors into the decisions we're making. And so very concretely, I think we've seen that approach be incredibly relevant during COVID, from disease surveillance and getting a comprehensive view of everything happening at CDC and nationwide, to providing research infrastructure that's really patient-centric and gives tools to researchers across the country and prioritizes EHR interoperability, to supply chain forecasting and identifying potential shortages. But all of that is about not just seeing that data and having a common operating picture, but tying it to the decisions that you can make, the places you can allocate resources, the places we need to we need to make sure there is stock and supply, the places and the tools that we need to empower researchers with to really drive the next round of cancer insights. And so I think that ethos of connecting data and analytics and now AI to decisions and its operational context is more relevant than ever, because working backwards from those decision points is the only way we're going to be able to make sense of this fragmented ecosystem.
So, we say you can't change what you can't measure, and Palantir is like the top of being able to measure things. How do people, in your experience, your customers, your agencies, how do they learn to act on data that they never had before? And how well are they doing at that?
Yeah. I mean, to be honest with you, Greg, the majority of our engagements, so first of all, Palantir is not a data broker. We're not showing up at our engagements with various federal agencies, providing them data that they then have access to. I think what we have found is that at the majority of these agency partners and a number of our commercial partners, the data a lot of the information is already there. And the ability to synthesize it and get it into one common format, location, and operational context, what we call the ontology, really provides unprecedented ability to make the decisions that are already being made just with a combination of PowerPoints and consultants and spreadsheets and dashboards, and really getting that built into software in a first-class way where the decisions operators are making every day is backed by the data the organization already has is really powerful and I think is doable. It's a matter of making use of what you already have rather than only prioritizing and discussing the things that you need to get access to.
Great. Joyce, thank you for joining us today. Let's take a fantastic voyage into our genome in the human. 23andMe has had a very successful run and actually asked me to be part of it before she even started it. And I had just agreed to help another genetic testing company, so I missed that one. But 23andMe started with spit parties. It had a little kerfuffle with the FDA at one point. It got through that. Now you're doing some amazing studies with a variety of companies, nonprofits, et cetera. What is your prediction about the future of genetic testing in society in terms of making it something that everybody has access to in a meaningful way? How does 23andMe thinking about expanding from the early adopters to people who have a diagnosis of some sort or another and then need to get checked to see what their genetics are, since most people still don't want to be tested in advance for things like Alzheimer's, et cetera. Some do, but most don't, I predict.
Yeah, I think from the very beginning, we've had customers who are like, great, you told me that I'm at high risk for something. Now what? Right? And I think one of the things that we've really wanted to help people to do is how do you reduce the friction to get to that next step? Because they're motivated. They found that they personally are at risk for something. What do I want to do? So, a few years ago, we acquired a company called Lemonade, which actually has telemedicine in all 50 states. And actually, quite recently, we launched a new product called Total Health. It involves exome sequencing. And as part of that, not only do people get, their genes sequenced, but they'll also have an interaction with a genetically trained clinician to really help them interpret what they need to do in the context of their genetics and in the context of their health, get lab testing if they need to. And I think really what we're trying to focus on, and you mentioned, they already have something, should they get genetically tested? But I think we really want to move that conversation to how do you prevent these things from happening in the first place? We have a very long-standing Parkinson's disease program. The person who ran that for a long time has Parkinson's disease himself. And his mandate to us when he left, he's like, we're going to cure PD by preventing PD, right? And so really what we want to help people do is get to a point where they can say, listen, I understand that this is what I'm at risk for. It's not my destiny. So what can I do today that's going to help me live that healthiest life, get to 100, and beyond? And so I think it is about using genetics to make it very personal for people, right, to really feel motivated. And so I think we are trying to take the first steps in that in 23andMe by sort of providing some bridge to clinical care. But certainly in the long run, we really need to try to integrate with the rest of the healthcare system, right? The reality is most people are going to get their care somewhere else. And so, we're really also now starting to work more with healthcare systems trying to talk about okay, so how can we start integrating genetic testing? We have, years of experience helping people to understand what it means, what do the genetic variants mean, Dr. Kayla said before, how do we educate people? And that's something that we've been working on for years. How do you make the weird wonderful? How do you make the things that seem complex actually quite understandable? And I have an immense faith in the average person, in their ability to understand, how to handle these things. But we really need to believe in them and try to empower them to take ownership of their own health, because they're going to be their own best advocates. Who cares more about your health than you? And so I think for us, really, that future of health is the consumer.
Does your prediction for the future of healthcare include 23andBaby, where every newborn gets a whole panel of genetic tests beyond what we do today?
You know, I'm not going to speak for the company. For me personally, as a geneticist, I think, you know, that's where, for most of us, that's where we see the future, right? I mean, there's already discussion about sequencing at newborn for screening for various conditions, you know, ones where you can intervene early, that sort of thing. But I think longer term, you know, you're going to get your genome sequenced very early on, and that information is going to be used in different contexts for you as you go along. Let's just say, right, like you carry, you're a carrier for cystic fibrosis. It doesn't really matter for you when you're 12, right? But maybe you're 28, you're looking to start a family, now it's very relevant. Now maybe you are, you know, 60 and you're done having a family. It doesn't have the same relevance anymore. And I think that's why, you know, genetic care is actually going to be like a lifelong thing, because what those things in your genome mean are going to change for you as your context changes over time.
Thank you. Thank you. One of the diseases that affects behavior the most is diabetes. I have leukemia. It doesn't really affect my behavior. There's really no behavior I can engage in that will stop my bone marrow from making too many white cells, other than to poison it. So, but when you have type 1 diabetes or you develop type 2 diabetes, it becomes an integral, hour by hour, minute by minute, meal by meal behavioral challenge. So we're lucky to have Jared here from Abbott, who's worked in this field for a long time. How do you see technology helping people adapt to the behaviors they have to live well with diabetes, whether it's type 1 or type 2? And what's your prediction on it, whether that's getting better or worse?
Yeah, it's a big topic. It's you know, an area that we obviously focus on at Abbott quite a lot. I'm an R&D guy by background before I ran the business, so you know, I was intimately involved in the development of some of our, you know, continuous glucose monitoring technologies that is our prime business these days. I think what we learned during that process, Greg, was, and we learned frankly from some failures. We learned from some products that didn't resonate, you know, weren't acceptable, didn't take off. But what we learned was, I think, you've got to start with the patient in mind, to your point, about how that's going to help drive behavior. You know, the product we make doesn't treat the disease. It gives people information to allow them to treat the disease. So how do you best put that, you know, into a patient's hands, someone with diabetes, type 1, type 2, whatever they may be, with the lowest burden possible, so they are willing to at least use the product to begin with. And then I think the other principle we've always come at in those, from that early learnings, is you have to design it with affordability and accessibility in mind from the start. I think that's really what we've managed to do with the Freestyle Libre franchise. Is we made it acceptable and easy for people to use, to take that burden of measuring glucose away, so no more routine finger sticks, you know, no more only having 3 or 4 results a day, which is really, you know, not enough data for people to really, you know, monitor and then adjust therapy. And then how do you drive that to the point where it can be affordable and accessible, and then get uptake? Because I think, you know, R&D scientists loved inventing cool things, but one thing I learned is, you know, innovation's pretty meaningless unless you can get into the hands of people and there's access there. So I think that's really a, you know, a way of making sure that if you can get that right, so people will use it, so they can change behavior without too much burden, you know, and they can frankly get hold of it and understand what to do with it. I think, you know, that's where you get, you know, the technologies that kind of can revolutionize the space. There's no doubt that the CGM space has been revolutionized this past decade. I think that other principle is something that we've tried to build on throughout Abbott. You know, we make many devices that do this sort of monitoring, whether it's in the diabetes space, cardiac monitors like our iCert, IQ, etc. Where now, you know, it's Bluetooth enabled through a patient's cell phone, 24-hour monitoring of arrhythmias, etc. You know, but I think again, unless you can get that accessible, usable, and into people's hands, the innovation is kind of pretty meaningless. And I think that's where I see it going forward. Now, as people who make devices that collect data, I think our job now is to make that collection so easy that the power of the data, you know, can then be used and the greatest benefit to as many people as possible. And we've got 50 billion hours of, you know, glucose monitoring since we launched the product. How do we really turn that into something that's got insight and real benefit to the population and, frankly, to the individual? So the personalization of what we can tell people now with that access to data, et cetera, I think is, you know, where I see us going in the future. And I fully agree with the other panel members. You know, it's, can you use that technology to take efficiencies and drive that into patient care? where many of the things the machines can do well, they can do, and you can leave the doctors to do what they do well as well. So I think that combination of ease of use, affordability, accessibility for the primary product then can enable all the power that can come from all the big data and the AI initiatives that we're all talking about.
Thank you. So Judy, what problem in the future of healthcare do you worry about the most?
I think it's going to be the importance of the health grid.
The health grid.
Yes. And your health isn't just going to the doctor at the hospital and the clinic. There's so much more than that. There's your social care, your behavioral health. It's dental. It's the payers, and how do the payers work with the providers so that your denials are much fewer and prior authorizations go quicker. So I spend a lot of time thinking and worrying about all the things that a person needs around that person, because it's consolidated. It's a lot of stuff you need. It's not just this little bit. And how do we get it all together?
And how can Epic help get it all together?
Well, right now we're working with the payers, and we call that payer platform, so that if you go to the doctor and you get an order, and the trick is it covered, is it not covered, is it denied? When the doctor puts it in, that will quickly come back to say, is it approved or not approved? So you don't have to wait weeks to find out. Mayo put that in, and with one of their payers, they reduced denials by 80%. So that, I think, is really going to be helping a lot. But there's so many places to go out to, and how do we get that data together and make sure that you keep the patient at the center and all the data around the patient? Because I think that's very important.
Same question to you, Hirsh. What healthcare problem do you worry about the most, and what's the Palantir solution to that problem?
Great question. I think everything Judy said resonates. The fragmentation of the system is really scary and complex, and I think maybe the hardest part of that is it feels really intractable. A slightly different answer is that I think if we had wanted to author a playbook as a country for how to be like maybe a little bit tinfoil hat, about how to issue a bio-threat against the United States, we couldn't have done a better job in the last 3.5 years. Our inability to collaborate, our inability to coordinate across all the different components of the private sector, the public sector, the payers, the providers, just getting our whole healthcare system into a single place where we could then respond effectively was very, very, very challenging. And so one of the things that concerns me is that healthcare is now a national security problem. I think that was made very clear, and I think there have been really tremendous and sort of laudable improvements in the way that the White House has launched, the Office of Pandemic Preparedness and Response. I think OSTP and the National Security Council are thinking about this more. But if we think about healthcare the way we think about national security, we need endpoint detection to know when potential biothreats are entering or exiting the country, particularly entering the country, which can take the form of wastewater surveillance. I think CDC is doing a lot of good work with the National Wastewater Surveillance System and the Traveler Genomic Sequencing Program. We need centralized infrastructure to be able to synthesize that information rapidly to drive potential action. And then I think we need a much more sophisticated doctrine on how the US partners with other countries to inform and respond to potential threats once they've entered our borders. And so I think a real doctrine of public health readiness and treating public health and our healthcare system as a national security problem is something I really believe is necessary. I think from a Palantir perspective, we fortunately have a lot of experience with national security and how to provide infrastructure that helps mitigate potential threats while really prioritizing privacy and security and appropriate audited handling of patient data or civilian data. And so I think that is something that I really want to see us continue to invest in, and that I think I would be really excited for Palantir to be a thought partner on shaping our approach to as a country.
Great. Joyce, same question. What keeps you up at night about health based on your experience at 23andMe, which is quite a long time now.
It has been a long time. You know, I mean, I'll say this both, I think, both from my experience at 23andMe and some of my own personal experiences, which is like, there's a misalignment of incentives, I think, in the system, right? Like, I mean, everybody wants to do the right thing, you know, everybody wants good outcomes and that sort of thing, but, you know, a lot of people, a lot of institutions, payers, they have to look at this at a population level, or when you're looking at guidelines, you're looking at a population level. Is it worth it to pay for screening everybody in order to get, you know, whatever, you know, outcome? But as an individual, you don't think of yourself as a population, right? And so, you know, maybe the screening guidelines don't cause me to get screened for factor V, but finding out if I have factor V or not is going to make a big difference if I want to get pregnant, if I want to be on birth control, if I'm going to have surgery, right? And so I think, you know, looking, how do we really enable people to, you know, get the information that they need, right? And centralize things around themselves. You know, we've talked a lot about fragmentation, and the one thing that really ties all the fragmented pieces of data around an individual in the system is the individual, right? And so I think one of the things that we really want to be able to do at 23andMe is like empower people, help people bring those kinds of data together. I mean, for example, I've like brought multiple sources of data together through my Apple Health app on my phone. We talked a little bit about mobile earlier. And, you know, there was a point where one of my physicians had done some blood work. She was like very concerned, just to be frank, that like I had like bone cancer or something because of, you know, like some increase in blood value. And I was able to go through that data and then show her, you know what, I think that this med might be the thing that's causing it. She's like, well, that would be very surprising to me, but I'm willing to give it a shot. And that's what it was. And that's the sort of thing that we really want to be able to enable people to do, right? Just bring the data together, gain those insights, and make those personal decisions that, like, you know, aren't necessarily based on population data.
Great. Jared, in the field of diabetes, especially given the new weight loss drugs, do you think we're going to enter in the future a golden age of diabetes care where we're going to be able to prevent it, type 2, and be able to provide non-invasive constant monitoring for type 1 patients, and through medicine overcome the behavioral problems that not all obesity is a behavioral problem. Let's get that clear. But you know, pharmaceutical companies that, the payers that have to pay for a lot of diabetes care, when you look at their portfolios of how do they hedge increased cost of diabetes, they buy stock in fast food companies. So when fast food consumption goes up, they make money that they use to treat the diabetes or pay for diabetes treatment. This is not a system. Do you think that we can get past that? Do you think we're actually getting to the point where diabetes can be corralled?
I think it's the most promising period we've ever been in diabetes in terms of, you know, the advent of the new agents, and obviously everybody's very excited by the new agents and what they could potentially do both in, you know, diabetes, pre-diabetes, diabetes, obesity, etc. You know, I think continuous glucose monitors continue to improve, linked to insulin pumps for closed loop systems. So it is about the most exciting innovation cycle I've seen in my many years in diabetes. I would come back to the concerns I would have would be access to those products, whether it's expensive drugs, whether it's, you know, closed loop systems that are pretty expensive overall. So I think, you know, that concern on access, affordability, health equity is really something we've got to think about as industries like Abbott in terms of what we can do in our part to make sure that, you know, some of these cost burdens, et cetera, are not added to at least. I mean, we don't bring, you know, products to market anymore in diabetes care, at least looking for price increases, which has been a traditional model. We don't. We've never taken a price increase on our, you know, multiple generations of Libre. What I would say as well is the advent of the digitalization of healthcare. You know, we talked about the iPhone. I mean, of our 5 million people using Libre every day, you know, almost half of those are using iPhones or you know, Android-based phones now to collect that data. That's a great opportunity in terms of democratizing the data, digitalizing it, and getting it to people who really benefit from it. And frankly, I think, you know, to Joyce's point, the individual themselves, one of the surprising things I think I saw when we first launched these products was it wasn't necessarily the patients talking to the doctors that was causing them to get improved glycemic control. it was happening immediately as soon as they saw what was happening. So I think that's, we shouldn't underestimate that power as well of being able to get the information into a patient's hands, a user's hands very easily, and what that can do for their own health as well. So, going back to the original question, Greg, I think we're in a position where we can see great technologies coming through both on the pharma side and on the device side. I just think we've got to be aware of, disparity in access and, the things that we see, particularly in a fragmented system like the US. We obviously operate around the world, and I see the benefits sometimes of being in a single system where you've got, a national database for people with diabetes, and how much that galvanizes your ability to understand what's going on, within there. And that's not the case at the moment in the US. So I think that's one of the things we've got to think about. And it is going to be, in the end, I think, an ecosystem of all of us playing in this space and trying to bring all of our best solutions together in a way that drives patient outcomes improvements while maintaining costs.
Thank you. So I've been Dr. Doom for most of this, so I'm going to back off Dr. Doom. Joyce, what is the thing that gives you the most hope for the future of healthcare?
I know I'm just going to be like a broken record, but I really just believe in people and their ability to actually act in their best interests if we empower them to do the right things. And, maybe I'm just an endless optimist, but you don't get into science and research if that's not fundamentally your mindset, because science is hard. And so, I think this whole really, people having better access to the data, even looking at the internet, right? You now have so much information at your fingertips that really empowers you to go do anything from purchase insurance or buy a house with way more information and knowledge than you had before. And I think once we get people into the mindset that they can do that with their health as well, I think we're going to see something very different. Just like you were talking about, when people get their own glucose data, they can make changes right away.
Judy, what gives you the most hope?
Two things. One, getting data to the patients. So how many of you use MyChart? Raise your hand. Okay. Or use it and don't even know you use it because it's under a different name, which is very common. More and more data going into MyChart and getting the patients more involved with their own health and better able to take care of it. And the second thing is we have now 220 million de-identified, deduplicated patients in Cosmos. And that's what we call this great big data set of data. And if you look up epicresearch.org, it shows you the studies that we do every week. And some of those studies are, I think, very important, have been picked up all around the country. So those two things, growing them, those are very neat.
That's great. Jared, what gives you the most hope? Short answer.
I think technology. I think at the end of the day, if we can get the technology right and make sure we're not driving unnecessary costs, then I think technology will move healthcare forward if we give it a chance.
Hirsh, as the youngest kid on this block, what gives you hope for the future of healthcare? Because you're going to experience more of it than the rest of us.
Thank you, Greg. I certainly hope that is the case. Look, I think what Jared said resonates. The role of the private sector in interacting with the public sector, I think we've seen a material shift in the last 3.5 years in how our public institutions embrace private sector innovation, bring it to the door. I think things like ARPA-H to the supply chain control tower at Asper are demonstrations of where private sector innovation and partnership is really being brought into federal decision making. And I continue to believe that there is a role that the federal government uniquely can play in driving healthcare innovation. And so seeing that really meaningfully change, I hope we continue the sort of acceleration of the way private sector innovation is brought into our day to day. And I think the advent of generative AI in the last 6 months provides even more opportunity for us to accelerate that. But I'm really excited about the way that that's progressed.
Cool. We have to wrap up, but just to be clear, all of you are on this panel. All of you know the problems in healthcare. All of you know what you're doing about it. All of you know the challenges for a better century ahead than what we had before, or at least not losing the progress we had before. So I hope each of you will answer the same questions I've asked the panel. What are you doing to build the future? We all know we are the problem. How can you help change us to make the next century of healthcare even better than the last one? which I have to say in 2023 looks very challenging. But hopefully by 2024, 2025, it'll look a little better. Let's give our panel a hand and thank you all for coming.